think it takes a special skill to walk into a patient's room, a patient you have never met before, who has never met you, and say to them, I think you need to have a heart transplant. This is how the process works.
Dr. Michelle Kittleson, welcome to eShadowing. Thank you for joining us tonight.
Happy to be here. Thank you.
I'm excited to chat with you about a very interesting specialty. One, it was funny, right before we hit record or hit go live, the heartwarming stories that come with heart failure and transplant cardiology. I won't admit it, but there's probably been a couple tears shed watching the videos of family members listening to their loved ones' hearts inside of someone else. Again, those heartwarming stories. So I'm excited. Hopefully we get some of those stories today with you. I'm just going to let you go and share your screen because you have an amazing slideshow to present with people.
Right.
And we'll get into some of these stories and your story as well.
Okay, beautiful. So we're going to talk today about advanced heart failure and transplant cardiology. I put a little subliminal message in there, the most amazing specialty ever. So why? Why is it the most amazing specialty ever? Okay, so what is advanced heart failure and transplant cardiology? Heart failure. So when someone has heart failure, their heart is failing, it's very exciting to me because there's lots of different causes. So the diagnosis is very interesting. You have to talk to the patient. You have to examine the patient. You have to do lots of imaging tests on the patient to figure out what could be the underlying source of their failing heart. And in some cases, you find a diagnosis that you can treat and you can reverse the heart failure and make their heart better. Sometimes that doesn't work. And if that doesn't work, then you know just through clinical intuition, gestalt, judgment, when they're down that slippery slope, when they need more advanced therapies. And what are those advanced therapies when their heart failure is really bad? Well, there's heart transplantation, a miracle, a gift of life. We'll talk more about that. There's mechanical circulatory support, entering the science fiction world of implanting mechanical heart pumps to assist or take over heart function. And then there's hospice, leading patients to that difficult transition where we're unable to cure them, but we still want to do everything we can to help them at the end of life. So that runs the gamut of what advanced heart failure transplant cardiology is. And this is a slide just to give you a sense of what we do. I think this is a really cool graphic. So what you see here is the quality of life and intensity of care over time of someone living with heart failure. So they're initially diagnosed and they don't feel so good, the onset of heart failure. There's always a risk of dying suddenly for patients with this condition, but in general, they kind of truck along feeling okay. They take some medications, but can generally live a good life, work, exercise, spend time with their family, do the things they love until they hit the gray zone. And pretty much the final common pathway of almost every kind of heart failure is the gray zone. And that gray zone is when their quality of life starts to go down and their intensity of care starts to go up. When the medications, the oral therapies, the pills they're taking stop working. And that's when you have to have the big decision points, mechanical circulatory support or transplant. Are the patient interested in these options? Are they eligible for these options? On the other hand, do they need something more like palliative care, hospice, transition to end of life? The ICD, the implantable defibrillator that you've placed that could shock their heart into a normal rhythm, do you turn it off? Do you think about hospice care? So that gray zone is a hugely important transition that is intellectually very satisfying. How do you know based on your clinical experience when a patient has gotten there? And it's also very emotionally fulfilling. How do you gain the rapport and trust of a patient and their family to lead them through these monumental life-changing decisions? Another way to look at it is like this, where patients live on this solid line, horizontal line, going along, feeling okay, doing okay. and then they hit the slippery slope. The slippery slope where their prognosis, instead of being measured in years, is now measured in days to weeks to months. And you have to decide, can I fix something treatable? Can I optimize something and turn the process around? Or am I looking at these three potential options of palliative care, transplant, mechanical support? And when we're thinking about mechanical support, let's talk about the science. I mean, this really, truly is science fiction. These are biomedical engineers, God bless engineers, right? Who sat around in their garages and they thought about ways that they could make a machine work like a heart. And then they put them together and they tried them in pigs and they tried them in cows and then they tried them in humans. So here are some options. The left ventricular assist device, because the left ventricle is the main, most important pumping chamber of the heart. And you have these little devices, look at that, as small as the fit in your palm of your hand, that are implanted directly into the left ventricle. And how do they work? They spin really, really, really fast. And that spinning centrifugal motion sucks the blood through the pump into the aorta to the rest of the body. And they're powered by a drive line, which comes out through the skin somewhere in the abdomen. It's about the width of your pinky, not so intrusive, but people who have these pumps are hooked up to batteries or an electrical outlet for as long as they have this device in place. So it involves taking care of a drive line, not forgetting your batteries, recharging them, etc. And what's really a good fast fact, okay, so when you're in medical school and you're seeing a patient with a left ventricular assist device, these are continuous flow devices. The heart is a pulsatile flow, pump, relax, pump, relax. These are continuous flow. They spin at anywhere from 2,000 to 10,000 RPMs, depending on the device, continuously. So patients with a left ventricular assist device often don't have a pulse. Yeah. So when your senior resident or your attending tries to freak you out and says, check the pulse on this patient, and there isn't a pulse, you will not be fooled. You will say, yes, Dr. Kittleson once explained to us that continuous flow left ventricular assist device leave patients without a pulse. Fast fact, don't forget it. You'll impress everyone in the room.
Yeah, and do it before you go check for the pulse. Well, based on the patient's history of an LVAD, I wouldn't expect to find a pulse with this patient.
That'll sound very, very good. Yes. Another random pearl, if you have a patient with atrial fibrillation and your attending asks you if you hear an S4 gallop, say no. Patients with atrial fibrillation do not have S4 gallop because they don't have an atrial kick. All right, random fast facts to impress
cardiology nerds,
friends, and influence people. Right. So that's the left ventricular assist device. Now, take it a step further. What if the left ventricle alone isn't the problem? What if the right ventricle is a problem too? What if the patient has a gigantic intracardiac tumor where you just need to take the whole thing out, but then there's no heart left? What do? Enter the total artificial heart, where literally the entire heart comes out and this 4-chamber 2-valve system goes in, which takes over fully the function of the heart. Similar thing now, there's 2 drive lines instead of one coming out, one that powers the left, one that powers the right. I mean, truly science fiction. So that's the science behind these devices, which are generally used as bridge to transplantation, meaning I know you're really sick, but a donor heart is a scarce supply, always the unpredictable and uncertain wait for a heart to become available. If a patient is going downhill while they're on the waiting list, it's putting one of these devices to buy them time, stabilize them, keep them alive until a heart is available. And some of these devices patients have had for a decade. So that's the science of it. Because the science is sort of exciting, but the human element is exciting too. Let me show you pictures of 2 patients living life to the fullest with their mechanical circulatory support devices. Now, these pictures are taken from the websites. These are promotional materials. I didn't have to get the patient's permission for it. You can see the patient on the left has a HeartMate 2 left ventricular assist device. She's got that harness. Those are her batteries that are powering the device. The drive line's coming out through her skin. You can't see it because she's got her purple t-shirt on. The guy on the right, has a total artificial heart. He's got 2 drive lines coming out, and it's powered with that little backpack suitcase thing sitting at his feet. Now, you can tell by that picture he's got a basketball. He must be tall. He is really tall. And that was part of the problem. He was so tall, 6'5", that heart transplants require a size match. So we knew we'd have to wait a really, really really long time. And so we had the total artificial heart device placed to stabilize him, bridge him until a heart transplant became available. He did so beautifully that Syncardia, the maker of the total artificial heart, then asked him to be one of their promotional campaign patients and speakers. So that's how it looks for someone to live with one of these devices. So that's MCS, mechanical circulatory support. What about transplantation? Because ultimately, when you are living with advanced heart failure, heart transplantation is the holy grail. And I'm going to tell you the beautiful story of heart transplantation, the serendipity of science. And what these three random pictures have to do with the story, the miracle of heart transplantation. And it is a miracle to me every time that so many areas of medicine converged simultaneously to make the miracle happen. So first miracle. So one of the earliest roadblocks to transplantation was actually surgical. Surgeons in the late 1800s, early 1900s, didn't know how to sew blood vessels together. That was a real problem because blood vessels were so delicate. And it took a French surgeon, Dr. Alexis Carrel, who was inspired by his mother's embroidery circle with the fine needles and silk embroidery thread. And he saw the fine work these ladies were doing, and he said, I should use these needles, this thread, to sew blood vessels together. He was actually nicknamed the father of the anastomosis, the fancy medical word for connecting things, and won the Nobel Prize for his work in vascular anastomosis. And that set the stage surgically for heart transplantation to be possible. So these amazing pioneering surgeons tried it in dogs, and then they tried it in other mammals and then humans. And what they discovered is as soon as they would implant the heart into the recipient's body, it would immediately become mottled and blanched and bruised as if there was some circulating factor in the recipient that was killing the heart immediately. And in fact, there were circulating antibodies because the donor heart was a foreign substance and the body was trying to attack it like it would any virus or bacteria or parasite or fungus. Then immunosuppression burst onto the stage. So the first heart transplant was actually done in Cape Town, South Africa in December of 1967. That's a picture here at Groote Hospital. And you can see that picture. It's really quite beautiful. I actually had the opportunity to go there, now 15, 16 years ago to visit some family friends. So of course, while there, I made a pilgrimage to Groote Hospital where they have the original operating room as a museum.
Wow.
And they have the original charts, like the handwritten, penciled in paper charts where you can see the very first patient's clinical course, the immunosuppression he received. And in the background, there is Table Mountain, which is a beautiful mountain in Cape Town, South Africa. It's called Table Mountain because the top is flat. And it's quite beautiful when the clouds roll over Table Mountain. They're called the tablecloth. Okay, random fast fact. It's really beautiful. But let's talk about it. So the first heart transplant was done in 1967, but the initial enthusiasm waned because the surgical stuff worked, but patients died within months of the transplant from either infection or rejection. Why? Because the immunosuppression wasn't there. Fast forward to the mid-70s. And that's where we get the fungus shown in the middle picture. So what happened in the middle 70s is a drug company called Sandoz, known today as Novartis, encouraged their employees to go on vacation with plastic bags to collect soil samples. It was their form of drug discovery. So these employees would go on vacation, they'd bring back soil samples to the lab at Sandoz, and they'd be tested for new compounds. And that is how this fungus, Polypocladium inflatum, was discovered. And from it, a compound that was originally tested as an antibiotic. It was a terrible antibiotic, but it was a great immunosuppressant drug. And from there, cyclosporin was born. Cyclosporin was approved by the FDA in 1983. And after that, transplant programs around the world took off. So that is the science and the serendipity of heart transplantation. So where are we today? So this is a figure from the International Society of Heart and Lung Transplant Registry. This is an important figure for a number of reasons. First, look at the N. Look at the numbers here. 120 plus thousand heart transplants over the past 2.5 decades. That's pretty amazing. Second thing, look at the survival. In successive eras, survival improves. The science is getting better and better and better. So that in the current era, median survival 12 and a half years, that is astonishing. Better than anyone can expect with end-stage heart failure, where survival can be measured anywhere from days, weeks, to a year or less. So people get a new lease on life. Okay, so that's everything I wanted to tell you about the science of heart transplantation, mechanical circulatory support, advanced heart transplant. Now I'm going to segue into me. So why did I decide I had to become an advanced heart failure transplant cardiologist? Okay, so I'm going to go through every step of the process: 4 years of college, 4 years of medical school, 3 years of internal medicine residency, 3 years of cardiology, and then 1 year of an advanced heart failure fellowship before, drum roll please, you get a real job. So what made me go to medical school? So for me, it was half foregone conclusion and happy accident, in the sense that I, in fact, am the 5th generation of doctors in my family. So both my parents went to medical school. That's where they met. That's where they fell in love and got married. My grandfather happened to be the dean of the medical school in India, where my parents met and got married, and then his father before him. So there you have it. I'm an only child, an Indian. I was told from birth, you will become a doctor, and I never questioned it. Okay, I'm going to listen to my parents. It's always a good thing to do. So 5th generation of doctors in my family stuck me in medical school. How lucky am I that from the very first day, it was like the coolest thing I'd ever done in the world. I loved every minute of it. And maybe it was those years of dinner time conversations that I could never understand, my parents going on and on about stuff, that I finally understood. But there was something so incredible to me. Every scientific fact seemed new and cool and exciting. So there you have it, medical school. Why did I do an internal medicine residency? Okay, so I felt I spent so much time in medical school learning all these facts, so many facts. And really, I felt that practically internal medicine was the most efficient use of all the knowledge I'd learned in medical school. Oh my gosh, what if I went into psych or OB? I would never use half these facts I spent so much time learning. So anatomy, biochemistry, pathophysiology, all nicely packaged in internal medicine. And of course, it also comes down to mentors. My most amazing mentor in medical school was an internal medicine doc, and he had the highest standards. I was terrified every day before I rounded with him on my internal medicine rotation, but that terror translated into preparation, translated into learning, and he backed up his high standards with lots of teaching and guidance. So for me, he was the epitome of what it meant to be an amazing physician. He always said, I learn something new from a patient every day. And I've taken that to heart, and I tried to do the same thing. In fact, I can actually think of today a new thing I learned from a patient. It's extraordinary. Okay, so then cardiology fellowship. How did I come to cardiology fellowship? So there's many, many reasons why I believe that cardiology is the most amazing specialty. One, I love the pathophysiology. It just makes sense to me. If you guys are studying physics, you've heard about Ohm's law, V equals IR. That's all of cardiac physiology in a nutshell. Cardiac output, mean arterial pressure equals cardiac output times systemic vascular resistance. It is Ohm's law personified. And I love that. It intuitively makes sense to me. Second thing I love about it, the history and the physical matters. There are cardiac diagnoses that you cannot make without a history or a physical, without talking to the patient and examining the patient. Unstable angina, a condition where you have chest discomfort caused by the heart. That's a unstable situation of a plaque rupture or scary stenosis. You can have a totally normal EKG. You can have totally normal blood tests and still have a blood clot teetering on the precipice of the right coronary artery. I know, I've seen it happen. And the only way you'll know is by talking to the patient and getting a sense of the trajectory of their story. I love that. And the physical matters. Heart failure, decompensated heart failure, you cannot diagnose based on a blood test, a chest x-ray. No, you have to look at the patient. You have to examine the patient. I love that. The evidence base is beautiful. There is a panoply over decades of randomized clinical trials to support the evidence base of what we do in cardiology. So I can go to a patient and say, I want you to take this medicine because I know it works based on trials in thousands of patients just like you. It will make you feel better. It will help you live longer. That being said, there's still the option of the art of medicine, but there's a lot of good science to rely on. How patients die, that sounds interesting, doesn't it? I found as I went through internal medicine training, as I went through the many rotations as a resident, there were some ways that I just emotionally couldn't bear to see people die. There were certain oncology, I didn't realize there were so many terrible ways for one's life to end until I did an oncology rotation. For me, pulmonary critical care, the intensive care unit, respiratory failure was really hard for me. Somehow the end of life of patients with cardiology sat well with me emotionally. I felt that I could deal with this, I could process it, I could help people. So that was important to me as well. And then mentors, it really always comes down to mentors. I had the most inspirational mentor when I was a resident, who was a cardiologist, and she was everything. The most amazing teacher, the most amazing researcher, the most amazing clinician. She could do it all, and she did it so well. And she took the stairs up to like the 12th floor. I mean, I still can't do that. But there was something so incredible about being inspired to try to follow her path. And then after cardiology, what about advanced heart failure transplant cardiology? Why that? Well, it comes down to, I do love the human drama. I love that feeling of after transplant where patients are reborn, where you almost don't recognize them because they've gone from someone who is so debilitated, so sick, so limited, to having a brand new, wonderful life. I love the drama. And I love that there's a little bit of everything. I get to take care of patients in the intensive care unit, which is really intense and stressful. I get to take care of patients long-term in the clinic. For over a decade, we formed these wonderful long-term relationships. I get to do imaging. I get to look at echocardiograms. I get to do procedures like angiograms and biopsies. So every day can be a little bit different. And again, you sense a theme here. It comes down to mentors. Some of the most amazing people I connected with as my attending physicians were advanced heart failure transplant cardiologists. And I loved their breadth of knowledge, their depth of knowledge, their ability to communicate with patients. I think it takes a special skill to walk into a patient's room, a patient you have never met before, who has never met you, and say to them, I think you need to have a heart transplant. This is how the process works. And to garner their trust and to lead them through that process. It's an extraordinary gift. So that's how I knew it was for me. So what does a week look like? What happens in the day, in the week of an advanced heart failure transplant cardiologist? So there are some little asterisky things there because, disclaimer, this is for an academic advanced heart failure transplant cardiologist without protected funded research time. So that's me. I love taking care of patients. I've never written a grant in my life, and I honestly don't want to. I love taking care of patients. I derive my joy and my fulfillment from doing just that. I do love teaching, but I don't want to write grants. So this is what a job looks like if that's the way your world works. There are some people who have protected research time. What does that mean? It means they write grants that give them a lot of money, part of it to do research, part of it to pay their salary. And as much as they do that, they do less clinical work caring for patients to pay their salary. I want my whole salary to come from taking care of patients because that's what I love to do. And then the second disclaimer is this is pre-pandemic in the sense that when one has 3 children who are not in school for a year, one's daily schedule gets a little bit compressed, shifted, the work gets done just in creative ways. But this is generally what my schedule looks like and what it soon, cross my fingers, will look like in the future. Okay, early mornings. I'm a morning person, love getting up early. And it's nice being on the West Coast like I am. So if someone wants a 9 or 10 o'clock meeting on the East Coast, I'm ready at 6 or 7 a.m. It works great, works well with the family time too. So early morning is meetings. Morning, we're talking 7:30 to noon and 9 to noon, whatever the day happens to be. If I'm on inpatient, we'll round with the team. There'll be medical students, there'll be residents, there'll be fellows, and there'll be some education with weekly chalk talks. If I'm an outpatient, there'll be clinics. It'll be the heart transplant clinic, the heart failure clinic. It'll be general cardiology clinic. I do still do general cardiology. I don't ever want to become hyper specialized. I like to see the breadth of cardiology. I think if you take care of patients that are really healthy, it gives you perspective to take care of the too sick and vice versa. And then procedures, heart biopsies, angiograms. And lunchtime meetings. Afternoon will be clinics. Whether I'm on service or doing inpatient care or not. Evenings are family time, and it's pretty sacrosanct for me that between the hours of 4 to 7, because I'm also the sleep whisperer, and my 3 children are all asleep in bed at 7 p.m., but that's a whole nother talk. But that time is pretty sacrosanct. That nothing gets in the way of bedtime. Bedtime must go on. But then late evening, 7 to 9 or 10 p.m., will be research and administrative work. So you find the time to do what needs to get done. So, okay, what's with all the meetings? I thought I'm just not protected research funding. Why am I going to so many meetings? Well, there's national committees that I love to participate in, guidelines, that heart failure guidelines is national consensus statements in healthcare, educational committees. Then there's institutional committees that I do within the organization of Cedars-Sinai, bioethics committees, peer review committees, fellowship committees, blah, blah, blah. So lots and lots of meetings and committees. But I think I have this ratio I like to do with how many things I say yes to and what I say no to. It's kind of like a formula of how much joy do I derive, how much professional fulfillment and advancement do I derive, and how much effort will it take? And then it's like joy times fulfillment on the top and is the numerator, and effort is the denominator, and you figure out if it's more than 1 or less than 1 before you decide to say yes. So that's what a week looks like. Oh, right. And then you don't have any funded research time, right? But I also do projects with residents and fellows and other institutions. And I also discovered later in my career this love of writing essays, poems, medical narrative, bringing the art to medicine. Okay, so what slide is next? Okay, so now we're going to talk about cases. So I'm not going to talk to you about super technical immunosuppression complications of transplant cases, because honestly, that's interesting. But I want to tell you more about the stories of being an advanced heart failure transplant cardiologist and how these stories have helped me become a better doctor. So I love this quote: good judgment comes from experience, and experience comes from bad judgment, but hopefully not your own. So you can learn from the mistakes of others, the experience of your mentors, in addition to your own. So I'm going to go through a few essays that I've published in medical journals. These are medical narratives about patient stories and what I learned from them. So let me tell you, we'll start with my first terrible diagnosis. I published this in the Journal of Academic Medicine a few years ago, where I went through a story of a patient I met as a 4th-year medical student, where, I was a pretty smug medical student. I knew all the medical facts. I was pretty confident in my medical facts. I kind of liked knowing a lot of stuff. I loved the facts of medicine. And so this woman came to the urgent care clinic. Her daughter brought her because she noticed a lump in her breast. 60-something-year-old woman. And I was the medical student, so I walked in the urgent care room, and the minute she pulled down her exam gown for me to examine her breast, I knew exactly what was going on. The mass was hot and red and stuck to her chest. The overlying skin was angry and inflamed and dimpled. It was the classic peau d'orange, as it's called, orange skin appearance of an inflammatory breast cancer, which has a terrible prognosis. And I knew all those facts. Those facts ran through my head the minute I saw her. And it was the first time I realized that behind every diagnosis, there's a tragic patient. I'd always enjoyed the facts of medicine. I hadn't really realized the tragedy behind it. So in this essay, I learned my lesson. One was that I'd always relish getting the right answer instead of thinking about the patient behind the answer. And now I see both sides of the diagnosis. It's terribly exciting to see a patient with giant cell myocarditis, unless you're the patient, right? And I always try to remember that. And, what I did with this woman, I was the medical student, and my attending and I went in and basically told her, well, there's something there. It could be an infection. It could be something else. Let's set you up to see some specialists and get some testing. But we never actually used the word cancer. And now, over 20 years later, I feel bad about that. I think I could have been more honest with her, not that I had the experience to do so at the time. So now when I make an awful discovery, I try to offer patients an honest differential diagnosis, going through the best and worst case scenarios, because chances are patients are thinking it, even if they haven't said it. And just for you to say it, say the elephant in the room, to give them an honest plan about their options is often very comforting. And finally, I always love to acknowledge that we may both have more questions than answers, but promise we'll make a plan to get the answer. So that's a huge part for me that I learned from this patient on how to give bad news, how to break terrible diagnoses. All right, let's talk about another patient. This is actually a transplant case. So there's something really crazy when you think about the heart transplant waiting list. Some patients are so sick that they have to wait in the hospital for transplant. And this is a story that I actually wrote, an essay I wrote that appeared in JAMA Cardiology with one of my fellows and with a patient. It was a patient I cared for who spent 142 days in the hospital, 100, all but 28 of those waiting for the transplant, and then before he was discharged home. And after he was about a year out from transplant, I sent him an email, and I sent my old fellow in training an email. And I said, listen, I think it's an extraordinary thing waiting in the hospital for a transplant. I know what it feels like for me as the attending physician. What does it feel like for you? And I tasked them both to write 500 words about what that experience was like. And I put it together in this essay. So I'll give you a few excerpts. So the fellow said, his safe passage to transplant was my responsibility. I think he sensed this and eased my anxiety during afternoon chat. So the fellow in training took so much of the burden on himself, even though it was out of our control. We had no control over when a heart would become available. We could try to keep the patient stable, but a lot of cardiogenic shock is beyond medical control. But the fellow felt that, and the patient, sensing that, offered him comfort. The patient, the attending, that was me, as I walked out of his room, I would give myself a mental shake, considering how to provide the right balance of tempered optimism and managed expectation to the patient next door and the 15 patients after that. And to me, it's always such a surreal experience that you have to compartmentalize. You deal with the tragedy, but then you open the next door to deal with something different. And you learn you have to care. How can you not care? But how to manage your caring and manage your emotions. And for the patient, I was constantly reading facial expressions, looking for reasons to worry, but the physicians all had the same game faces. Their optimism and confidence, however unrealistic, were a constant anchor. And so to me, the beauty of this 3-part essay was that we were all scared, and we were all trying to comfort each other. And in the end, that shared comfort was actually a beautiful thing. So that's a story. And then finally, let's go through a story, an essay I wrote for the Annals of Internal Medicine, which talks about the privilege of grief. So speaking to what happens when something awful happens to a patient. Now, you may have heard that there are, Elizabeth Kubler-Ross has the stages of grief, denial, anger, bargaining, grief, acceptance. And that's what a loved one may go through. But what does a doctor go through? And I had fashioned these stages consciously, unconsciously for myself, and I teach them to trainees as well, to process when something awful happens to your patient. So step 1 is you separate fault from fluke. You ask yourself, did I do something horrible, or was it just bad luck? And if you did something horrible, and mistakes will happen, then you talk to your trusted mentors and your colleagues and you work through it so it never happens again. If you decide it really was fluke, there was nothing you could have done to control the horrible outcome, the next step is, did you expect it? You have to distinguish the unforeseen from the expected. Because something horrible happens to a patient, and you should have been able to predict it, even if you couldn't control it. It is your job to prepare the patient for it. If a terrible outcome is foreseen, for example, when I walk patients to the process of a heart transplant evaluation, I will tell them, A heart transplant is a miracle and a gift of life. It comes with its own sets of problems. But we play the odds, and we know that your odds of living a healthy life, doing all the things you love to do, are greater with a transplant than without. There's no guarantee, but I'm preparing you for the best and worst case scenarios. And then finally, accept that control is an illusion, because there will be patients, no matter what you do, who horrible things happen to. You might have heard that joke. What's the difference between a doctor and God? God knows he's not a doctor. We have this element where we think we can control everything, but you know what? We can't. And there's a certain amount where if you know it wasn't your fault and you did everything you could to prepare the patient, you must be at peace with what happened so that you can preserve your emotional endurance for the many patient years to come. And then one last story I'm going to tell you about predictions, about how much of what we do in medicine in general and a transplant in particular is trying to predict the future. Will my patient do well? Will my patient do badly? Did I make the right decision? Did I predict the future? I'm going to tell you about two different patients. Mr. R was listed for transplant as an outpatient. He was actually quite healthy. He was working full-time, but his heart was weak, so he was listed for transplant. Post-transplant, he had a terrible course. He was on ECMO, extracorporeal membrane oxygenation, because his heart failed immediately after transplant. It eventually recovered, but he had a tracheostomy. He had pancreatitis. He had heparin-induced thrombocytopenia, which is a bad reaction to heparin, leading to blood clots throughout his body, resulting in toe amputations. Long term, he has migraines. He has coronary vasospasm, which is a spastic process of the arteries that leads to a lot of chest pain. He's been on dialysis because his kidney failed. And I once worked up the courage to ask him about 10 years after transplant, do you regret this? Because you've had a rough course. And he said to me, no, I've lived. I've seen my son graduate from high school, almost graduate from college. I have suffered, but the suffering was worth it for me. But ultimately, I wonder, going back 10 years, if he should have been listed for transplant. Was the judgment bad or was the judgment good? And I worry that the judgment might have been bad, that maybe he didn't need a transplant at all. Contrast that with Miss S. She was really sick. She was an inpatient. She was inotrope dependent. She needed continuous intravenous medication to support her heart function. She had weeks to live. She needed a transplant. She had a terrible post-transplant course too. She had multiple strokes resulting in an inability to talk, aphasia, weakness on one side of her body. A year later, she could talk a little. She walks with a cane. And I asked her, I worked up the courage to ask her, do you regret having a transplant? She said, yes, absolutely. I would have rather have died. But the question is, if I could go back in time, would I not list her for transplant? No, the judgment was good. And so the lesson, because she would have died without a transplant, and if you're playing the odds, you cannot judge yourself by the outcome. You must judge yourself by the soundness of the medical decision making. And this is something I teach residents and fellows all the time, that if your judgment was good, you must make peace with the outcome. You will grieve it, and you will shoulder that responsibility. But when the next patient comes along that looks just like that patient, will you do something differently? So when I have a patient like Mr. R, who's an outpatient with heart failure, who's working, I think twice before I list them for transplant. Because if a horrible thing happens afterwards, can I live with it? Did I play the odds right? But if I have a really sick patient who I know won't live, I can live with a bad outcome because I know the odds were in my favor. So a little bit about how medical decision-making works in transplantation. So medical decision-making is an enormous responsibility when we get it wrong and even when we get it right. And as a person, we absorb the grief, the anger, the frustration of every tragedy. But as a physician, we have to focus on the questionable decisions, not the bad outcomes. And then, I have one last story, and then do we have enough time, Ryan? Can I keep on yammering on? Okay, great.
Yeah.
So this story. So I'm particularly proud of this essay on it. I'm gonna humble brag for a second. I hate it when people do that. But if I tell you I'm humble bragging, that cancels out the annoyance that I'm humble bragging. So it was always my dream on my bucket list to get a medical essay published in the New England Journal of Medicine, big journal, fancy. And I was really excited when this came out in the New England Journal. Okay, so it's a story of me and a patient. It was a patient I cared for who was really sick, waiting in the hospital for transplant. And I did all the right things. I got him to survive to transplant. He was getting sick. I tweaked his medications. I stabilized him. I fought with his insurance company. I mean, I did everything right. He flew through transplant. He did amazing. Medically, A+. You know what I did wrong? I never spoke to him. And the reason until he was an outpatient, and the reason I never spoke to him is because he was deaf. His father was always in the room translating. I never took the trouble to get a sign language interpreter in person because in the narrow space of time where rounds would occur, the logistics befuddled me, confounded me. I didn't get a video sign language translator because he said, I don't want one of those. That doesn't make any sense. And I relied on his father, and I never spoke to him directly. And when I met him for the first time in clinic with a translator there, and him and me and a translator, it was the most amazing thing. He was the coolest person. He was joyful. He was funny. He was appreciative. And then I worked up the courage a few visits later to say, I'm really sorry that I never took the time to speak to you in the hospital. He was so gracious. He said, I get it. You took good care of me. I understand the logistics of it. He was so gracious. He didn't have to be. He was so thrilled by his new life. But what I learned from this patient was this. I fell into a complacency born of pragmatism and confidence in my abilities. I knew I was providing the best medical care, so I ignored the importance of direct communication. And what I learned was diseases may become routine with experience, but patients must not. And that was a really important lesson for me. And then I'm going to end with a poem that I hope sits with you as you move on in your medical career. You will focus on your mistakes and you will learn from your mistakes, but you should also learn how to cherish the victory. So this poem is called Mistakes. I keep the notes from grateful patients in my second desk drawer. For mistakes, I keep a mental file that replays on nights I can't sleep. The near misses, the misdiagnoses, the wrong decisions live there. Anxious, overweight dyspneic, I almost didn't order the CT. Mitral valve prolapse, fatigue, and night sweats, I missed endocarditis. Cardiac sarcoid, steroids or transplant, I chose wrong and she soon crashed. The stash of kind notes never sees the light, but the mental file stays fresh. Happy endings, all alike, but every mistake cuts in its own way. And I end with that to remind you to keep the kind notes and don't just keep them, but read them. Celebrate the victories, the tiny joys, the wonderful things you'll do to help your patients. And that's everything I wanted to say.
Awesome. That's a great place to finish up. Someone just posted where'd it go? It said something about this is the first time Dr. Gray hasn't said anything during a presentation.
Oh my God.
They loved it.
It.
No, they love everything that you're talking about. So thank you for sharing all of that. Let's go ahead and raise some hands. We'll bring some people on to ask some questions for the last few minutes here. One question that came up earlier, more of a technical question that I think was interesting, just to differentiate as well, is how do you differentiate a transplant between the question was, how do you know when to do a transplant versus a cabbage?
Oh, great question, of course. Okay, so transplant is a scarce and precious resource and comes with its own problems, immunosuppression, complications, etc. So the rule of thumb is you do whatever you can to make the existing heart as perfect as possible. And you only go to the last resort of transplant if you've exhausted every medical, electrical, device, surgical option first. So if cabbage is an option, surgical revascularization, meaning you think it's going to make the heart get better, you think the patient's going to live longer, the surgeon thinks it's technically feasible, that's always the right answer.
Yeah. Yes. Great. All right. So we'll bring on some people, including fan favorite Shane. We'll give them a second to come on. And then another question, someone asked, why did you get your PhD as well? What was the thought process behind that?
Yeah, great question. So I actually got my PhD during my fellowship. Okay. So I didn't do that MSTP 8-year medical school thing because I really wasn't interested in basic science, so I wouldn't want to. 4 extra years of doing basic science would have killed me. But during my cardiology fellowship, there was an option to get a PhD in clinical investigation, essentially epidemiology and biostatistics, concurrent with the 4-year cardiology fellowship. So I took no extra time and was able to do a lot of teaching. So one reason was a very efficient use of time. It was an area I was interested in. And lastly, I almost did it to prove to myself that I did not have a passion for research. So I knew I was supposed to have a passion for research, but I didn't really. And I figured there's this great program. If I can go through this whole program, if I can get a PhD and I still don't have a passion for research, it's not sour grapes, it's just me. And so really that was the other reason I did it.
Awesome. All right, Shane, welcome. Hello.
Hi. So I had a question about the field in general. So you kind of talked about like the biggest breakthroughs that kind of led to heart transplant surgery. I'm kind of curious, what do you see is the next biggest barrier, the next biggest hurdle that transplant is facing, and when do you think that might be overcome?
Yes, two major things. First, these left ventricular assist devices are really extraordinary at this point. The most recent iteration is magnetically levitated, so there's no touching parts, so there's no wear and tear, so they could last like 100 years. So the new devices are really amazing, but the one problem is there's that driveline that comes through the skin. And that driveline that comes through the skin is driveline infections and tugging and pulling and annoyance and decreased quality of life. And then the batteries. So there will be in the future a completely self-contained device with no driveline through the skin that allows for transcutaneous powering. And when that happens, I think we'll be in a whole new world of left ventricular assist devices taking over much more of the transplant market, as it should, since transplant's the rate limiting step. And then the second thing, is the supply of donor organs. There's a scarce and precious supply, but there are ways to expand the donor pool. There are actually ways ongoing. A heart is only good outside the body for about 4 hours. Kidneys, livers, 12, 24 hours. Hearts are very delicate. So you can't really go that far away to get a heart unless you can't put it on ice, unless you can keep it in its beating state, in a physiologic beating state. Well, then who knows how you can go to across the US to get a heart. That's one of the next iterations of expanding the donor pool.
Awesome. Thank you so much.
Thanks, Shane. It's interesting, Michelle, as you mentioned that. I always tend to think of, and I'm not a negative person, I'm a very positive person typically, but in that situation where we extend the range of where we can get donors from, I think of bad people doing bad things in third world countries and shipping hearts to places that have the money to pay for it. And I just
in fact, there are huge societies, philanthropic nonprofit organizations dedicated to the non-ethical use of organs.
Yep.
I'm very happy to say I think many things in life are not fair, but I believe the organ transplant allocation system as it exists in the US is really a wonderfully fair system. But you're right, other parts of the world it's concerning.
So here's a question for you, and Shane, I'll bump you off here. So organ transplantation is very near and dear to my heart. My dad was a type 1 diabetic, needed a kidney transplant when I was very young. I remember the day that he got the news that he was getting a transplant. We have for the most part in every state, we have an opt-in organ donation system.
Yes.
I love talking about this because a lot of students don't necessarily understand the difference, and it's a very good question potentially for medical school interviews. What is your stance? What is maybe the stance from on a society level for trying to force an opt-in or an opt-out system nationally?
Right. So the question right now, even if you have that sticker on your driver's license or whatever the Facebook notification is, that actually doesn't count. If God forbid a tragedy happens to you and you are rendered brain dead and your organs are acceptable, it is your next of kin, whoever's next in line to be your decision maker legally, who makes that decision. Can you donate your organs or not? There are some places in the world, Spain in particular, that has presumed consent, where you're presumed to be an organ donor unless you opt out. So and the rates of organ donation are much higher because it's a societal expectation that, of course, I don't know if the US as a society will ever get there. I think there's a lot of distrust in the medical system, for better or worse.
Yep.
Certainly there's history to make that so.
Yep.
So that there's concern that, will someone kill me? Will they hasten my death because of organ donation?
Yep.
So I worry that we'll never be able to get there as a society with that level of trust, but absolutely that would be huge for the power of organ donation.
Yeah. Oh, Zara, welcome. We cannot hear you. You just muted yourself.
Oh, my bad. Sorry.
There we go.
So I was kind of wondering what drove you to follow your path towards this kind of patient population rather than other types of patient populations.
You know, I love the science of it, and I love the connection you can make with patients. I love the ability to enter the room and immediately form a rapport of trust that's based on knowledge and expertise, but takes emotional intelligence and a human connection. And I love being able to use all skills together to care for patients. You know, I think some people gravitate to more shift type specialties like hospitalist or emergency medicine, or some people to more technical things like radiology that have maybe, or pathology with more limited contact. For me, the things that might make medicine sometimes more irritating also make it more enjoyable. Like, yes, are there patients who drive me nuts? Yeah. And do I sometimes tell them because I know them so well? Yes. But that's part of the joy. You don't build those relationships, those amazing long-term relationships that bring so much fulfillment. There's the good and the bad. So I love putting in the effort and the time, which I think reaps so many rewards. So for me, you know, I didn't want to just run in, do an angiogram, pop in a stent, save their life, and run out of the room and never see them again. To me, the more cerebral thought process of how do I get them to the right place and communicating them through it was important to me.
Thanks, Zara.
Okay, great.
And Nikita, we'll finish off with you.
Can you hear me?
Yeah.
Yes.
Oh, okay, cool. So I have a question. You said that sometimes, you know, there is nothing you can do to help the patient because, you know, you cannot transplant the heart, you cannot do anything. So you need to transit to the hospice. And you said that for you, seeing people die from a heart failure is different and you can bear with it. Can you talk how is it different in more details, and also how do you tell your patients about this? Because basically what you're telling them, you know, you're going to die.
Yes. You know, it's hard to say. You know, I remember doing an oncology rotation when I was in medical school, and there was a young woman dying of breast cancer who had a tumor eroding through her chest wall, and I couldn't wrap my mind around that. Or seeing the stem cell transplant unit and just the ravages to the immune system and the infections and the bleeding. It seems so barbaric to me that why can't you do more? This doesn't make sense. Whereas I guess I can't really explain it emotionally, but there was an affinity. You know, my grandfather had ischemic cardiomyopathy. He passed away when I was a resident. Perhaps that was part of the process. He died. He lived a wonderful life, and he had a very peaceful death, and nothing felt unfair. I mean, it felt like, okay, this is your time. And sure, young people get heart failure, and I see terrible tragedies. But for the most part, I feel like I can reconcile the science as well as the tragedy in my head. That's probably not a really good explanation for it, but that's where it is. Now, how do I tell patients? You know, I'm a firm believer. I have certain rules I try to use when I'm breaking horrible news to patients and their families. First, I have to be confident that I'm 100% prepared and confident in my assessment. And oftentimes that involves my colleagues, where I will run things, and we have a committee where we run through many cases together on a weekly basis. We all agree that there are no other options. So I have the weight of expertise and experience on a scientific level from so many areas. So that's the first. You have to be confident in the science of your medical decision making and relay that. And the second thing is, I always make patients a promise. I will be honest with you. And even if it's something you don't want to hear, or if that's bad news, I want to give it to you, because I will never do something, prolong your life just for the sake of prolonging it. And the next thing is to always couch things based on the patient's goals, values, and preferences. And for some patients, additional suffering has meaning towards a goal. I need to stay alive because I still want to see my kids and they can still come in and visit me, and this is important to me. And there are other people who say, if I can't, go sailing, it's not important to me. So you have to reconcile the patient's goals, values, and preferences. So I'm going to be honest. I'm never going to ask you, a patient, or your family to make medical decisions. That's my job. But let me help you make the right decision among these options based on what's medically feasible and what your goals, values, and preferences are. So that's how I like to think about it.
Thank you. Yep.
We had a great presentation 2 weeks ago from BJ Miller, hospice and palliative care physician, who's phenomenal. Have you heard of him at all?
He sounds. I'm gonna go back and listen to it.
Go listen to his TED Talk. He's a phenomenal guy. He's a triple amputee, had an electrocution in college, and just phenomenal guy. I think that's a great, for anyone watching who didn't watch BJ's talk 2 weeks ago, kind of a follow-up to this conversation. One more quick question as we wrap up here. Obviously, we're in the middle of a pandemic that seems to have some potential complications for the cardiac world. Where have the conversations gone in terms of long-term cardiac complications for COVID patients?
Yeah. I think we don't really know. I think just because you can take an MRI and see an abnormality on an MRI doesn't necessarily mean there's relevant clinical implications. I mean, they don't MRI everyone who gets the influenza, so I think we don't know. Now, for heart transplant patients, there is good data to show that their mortality is quite high from COVID, as would be expected. They are older with comorbidities and they're on immunosuppression. Yep. So how I deal with that conversation, is it's how comfortable. Transplant patients are used to living with risk. You have to wash your hands. You have to stay away from sick people. Early on, you avoid crowds. Later on, you can be a little more comfortable with it. And COVID's just another layer to that. And so they understand that even when they're vaccinated, they're not 100% protected because their immune system, it's not clear how they'll respond to the vaccine. So I guess it's all about, it's never an edict. You must not, your daughter's getting married next week and it's 10 people at the wedding, everyone's in mask and distance, but you can't go, right? It's, well, what are the risks of going? What are the benefits of going? Let's figure out where you sit on that continuum.
Yeah, my father-in-law unfortunately had to start chemo during all of this pandemic as well, gosh. and he is a zero risk type person, so it's been a interesting conversation with everything going on now that vaccines are available and kids are going to need to go back to school. Our kids have been out of school mostly because of that, and so yeah, it's hard. Definitely interesting conversations.
There's no such thing as zero risk, right? Everything you do has risk somewhere. Sometimes you can see it, sometimes you can't. Yep. It's just keeping your eye on everything.
Yeah. Well, Dr. Kittleson, thank you so much for your conversation. Students loved you so much. They keep talking about your passion is just exuding from your conversation. So thank you so much for coming on and spending some time with us tonight.
Cool. Thank you. It was really fun.
Yeah. Have a great night. Bye, everyone.